shoot it like you put it.
That's a wait and Lediga Ilandono. That's a start to you.
Sorry, ഞാൻ ഉണ്ട്. ഞാൻ മാഡത്തെ ഒന്ന് താഴെ കൊണ്ടാക്കാൻ പോയതാ.
Matthew undo. Matthew.
ഉണ്ട് സാറേ.
You can start.
Sir, തുടങ്ങട്ടെ. It's my pleasure to visit the lead discussant for today, Dr. Mini S, Professor, Department of Pediatric Neurology, GMC Trivandrum, SCT Trivandrum, and also she has done a fellowship in epilepsy. And we are very happy to have you, madam. Welcome you, madam, for today's program. And today's case is from MOSC Medical College, Kolancheri. And mentor for today's program is Dr. Verghese Abraham, Consultant Pediatric Neurologist, MOSC Kolancheri. I invite Dr. Verghese to introduce the case as well as the presenter.
Before that, I think Dr. Anandageshan sir will talk a few words.
Very good evening, respected. I cannot see any IAP officials. Anyway, respected Puchum sir, Sushma madam, and Dr. Jose, immediate past president, and Dr. Verghese, Dr. Mini madam, and Dr. Chitalaga madam, and all dear Dr. Isaac Matthew, and all dear friends. Very happy to see that we are getting varieties of cases every week. We are having different types of cases with very good enthusiastic discussion, and also very good input from not only from the mentor but all the teachers, which was Sushma madam, Srinivasan sir, everybody actually participating in this academic program. Very happy to, and Dr. Mohandas also very keen in conducting well advanced. I think announcement of this meeting 5 days back itself. So everything is going very nicely, and I wish the program all the success. Thank you, Jai Hind IAP. Thank you.
Now, mentor of today's program.
Good evening, all. Good evening, respected seniors, friends, and colleagues. On this occasion, I would like to thank the Indian Academy of Pediatrics Kerala branch. As a part of this presidential action plan, we are PG training case presentations. On behalf of the Department of Pediatrics, MOSC Medical College, we would like to thank the IAP for giving us this opportunity. Today, we will be presenting a case of an ascending paralysis and how we went about it and how we made a diagnosis of it. And our presenter will be Dr. Maxilin. She is third year junior resident, postgraduate resident in our department. And we are happy that we have with us Mini Madam. Mini Madam is a very approachable person and a very good teacher, and she's from Trivandrum Medical College, one of the centers where few centers in Kerala where DM pediatric neurology program is there. She's a professor of pediatric neurology from Trivandrum Medical College. We would like to welcome Maxilin. You can start the screen and start presenting.
Good evening, all. Today, I am presenting the case of a 5-year, 6-month-old male child residing at Ernakulam, whose informant is mother and information is reliable.
Maxilin, can you make it slideshow?
No, sir. Slideshow.
Full screen
That bottom button on the right lower corner.
Yes, just above that, right. Yes. Yes.
Presenting the case of a 5-year, 6-month-old male child residing at Ernakulam, whose informant is mother and information is reliable. Presenting complete.
Still that slideshow is not there.
Sir, this slideshow taken, sir.
You can click the button at the bottom line where
On the right-hand corner on the
near
bottom.
that 75%, there is another button for slideshow. Bottom.
No, not there.
That also maybe from current slide you can.
Start slide.
Sir, it is not coming, sir.
Okay, you can.
You can just share the screen again. Definitely.
మమ్మీ పని చేసింది
ഹലോ എന്തുണ്ട് എനിക്കൊരു ക്ലാസ് ഉണ്ട് മമ്മിക്ക് കൊടുക്കാം
മോഹൻദാസ് ഇതിലേക്ക് പോട്ടെ
കുഴപ്പമില്ല.
വായിക്കാൻ പറ്റുമോ നമുക്ക്?
You
I'm
can
listening to
continue.
one class.
You can continue. Next.
Presenting complaint. Irritability for 7 days. Severe pain over the both lower limb for 7 days. Unable to walk for 4 days. History of presenting complaint. Child was apparently well 1 week back when the parents noticed irritability. Child was irritable throughout the day, not associated with fever, headache, altered sensorium, vomiting, or seizure. Child also complains of severe pain over the both leg since 7 days. Pain was diffuse in both legs, exaggerated with exertion and restricting the daily activity. Gradually, in the next 2 days, child had difficulty in walking, which started in the form of slipping of chappals while walking, followed by frequent buckling of knees and unable to get up from sitting position. By day 4 of onset of illness, child had difficulty in buttoning the shirt, unable to lift the teacup, and difficulty in lifting the hand above the head. Parents also noticed that the child had difficulty in getting up from lying down position and difficulty in lifting the head from the couch. On day 6 of illness, parents noticed that the child is unable to close the both eyes. The speech was slurred, reduced facial expression like smiling. He also complains of drooling of saliva and difficulty in drinking water and difficulty in blowing. Currently, the child is bedridden and completely dependent for daily activity. No history of altered smell, no history of blurring of vision, ptosis, squint, no history of difficulty in chewing, reduced sensation over the face, no history of deviation of angle of mouth, no history of difficulty in hearing, no history of difficulty in swallowing, change in voice, nasal regurgitation, no history of difficulty in turning neck to side, no history of difficulty in protruding tongue and deviation of tongue. No history of numbness, tingling, loss of sensation, burning sensation. No history of paresthesia or anesthesia. No history of bowel and bladder disturbance. No history of breathing difficulty. No history of diarrhea, palpitation, sweating, or flushing. No history of easy fatigability, waxing and waning of symptoms, diplopia, restriction of extraocular movement. No history of vomiting, headache, seizure, altered sensorium. No history of recent vaccination, back pain, dog bite. No history of trauma to spine. No history of rash, drug intake, pica. No history of swelling in the neck, sore throat with patch. No history of dark colored urine. No history of abdominal pain, photosensitivity. No history of polyuria, polydipsia. No history of heavy carbohydrate meal or heavy exercise before the onset of symptoms. No history of ingestion of honey or canned food substance. No history of recent travel to the hilly or tropical thick forest, sleeping in the floor or insect or snake bite. No history of similar episode in the community. Moving on to past history, 3 weeks back, history of fever for 10 days associated with cough and URA and was managed with IV antibiotic. No history of similar episode of weakness in the past. Antenatal history, second born of non-consanguineous married parents, marriage, no maternal comorbidities, no normal antenatal scan. Natal history term baby delivered by LSES in view of previous LSES cried soon after birth. Birth weight of 2.9 kg. Natal postnatal history, NIC admission for 1 day for neonatal jaundice, received phototherapy, discharge on neonatal day 5. Developmental history, all milestone attained up to age, no developmental delay, studies in UKG, good scholastic performance. Dietary history, he is deficient of 150 kilocalorie and of protein excess of 6 gram per day. Immunization, immunized up to age, last dose at 5 years, no optional vaccine taken, BCG scar present, no AEFI. Family history, no history of similar complaint in the family. Socioeconomic history, mother studied up to degree, now housewife, father studied up to 12th standard, working in a factory, BPL ration card, source of drinking is from well, socioeconomic class, lower middle class according to modified Kupusami classification. Coming to summary, 5-year, 6-month-old male child, second born to non-consanguineous married parents, developmentally normal, immunized up to age, with history of respiratory infection 3 weeks back, presented with acute flaccid paralysis, characterized by symmetrical ascending weakness of limbs and trunk, and with bilateral facial palsy without involvement of respiratory muscles, higher mental functions and sensory system normal. Coming on to clinical localization.
Can you just hold on and then describe why you the symptoms, initial symptoms, and so many negative history also you have told. What is the relevance of those things? So according to you, this is a child who is 5.5 years, right?
Yes,
He was
madam.
pre-morbidly normal child who had an irritability of 7 days duration, followed by some at the same time pain also, right?
Okay,
And
yes, madam.
inability to walk for 4 days duration, who rapidly became bedbound. Is it not?
Yes, madam.
Okay. So how do you account for that pain and irritability in the beginning and then weakness? So where all in the neuraxis these symptoms can be localized?
Irritability can be cortical lesion. There will be irritability and
So
severe.
rather, irritability is whenever a child is sick, due to whatever be the reason, whether neurological, non-neurological, when the child is not well, they can be irritable, right?
Yes, madam.
So irritability is a non-specific symptom as such. But as far as neurology is concerned, irritability, when there is an irritability in a small child, in an older child, it may be like personality changes and all. Irritability is taken for sometimes as a sign of or symptom of encephalitis or encephalopathy. But along with that irritability, you said during the same time there is something else also, pain.
Pain
right?
also. Yes, madam.
So that is the most important reason why the child has become irritable in this case, right? So
Yes,
pain.
ma'am.
So how do you
mainly,
explain that pain?
Pain
Can you be little louder?
You are poorly audible.
How do you explain the pain now in this case?
Here, pain is severe and also continuous in nature. It can be mainly root pain can be present like this.
So what are the features of root pain? Why do you call it root pain now?
Root pain is mainly sharp shooting pain, which is exaggerated by coughing or any while we are doing any exertion.
So you have mentioned exaggerated during exertion or walking, right?
Yes, yes, madam.
Activities. Okay, then what other pain can occur in such a situation? What can be the other cause for pain when there is a weakness? You have told weakness.
Muscle pain can be present.
Muscle pain can be there. Any other cause for pain? Radicular pain, muscle pain. Then pain of the peripheral nerves also.
Peripheral nerve pain also there.
Be radiculopathy. Pain arising from the peripheral nerves. Also, it could be a muscle pain. Right?
Yes, madam.
Am I not audible?
Poorly audible.
കുറച്ചുകൂടെ മൈക്കിന് അടുത്തേക്ക് വരികയാണെങ്കിൽ.
Probably then I'll switch on my mobile and then come. I'm using.
മോഹൻദാസ് എല്ലാരും ഒന്ന് മ്യൂട്ട് ചെയ്യോ? മോഹൻദാസ് എല്ലാരും ഒന്ന് മ്യൂട്ട് ചെയ്യോ? എല്ലാരും മ്യൂട്ട് ചെയ്യേ, ഭയങ്കര ഡിസ്റ്റർബൻസ്.
All are muted, I think. Hello, Mini, you are muted.
ഇപ്പൊ കേൾക്കാമോ?
കേൾക്കാം.
ഓക്കെ, ഒരു മിനിറ്റ്. ഞാനപ്പോ എന്റെ ലാപ്ടോപ്പിൽ നിന്നുള്ളത് ലീവ് ചെയ്യാം. ഇവിടെ കണക്ടിവിറ്റി കുറച്ച് പുവറാണ്, അതാണ്. ഇപ്പൊ കേൾക്കാമല്ലോ, എക്കോ ഇല്ലല്ലോ അല്ലെ? സോ ഐ വാസ് asking the causes for pain in such a situation when there is a weakness. So she told there can be radicular pain. She mentioned about the features of radicular pain. Then she may also mention the features of she also told it could be a muscle pain or it could be a nerve pain also. Is there any other reason why there can be a pain along with weakness?
Cord compression pain.
Okay, so what do you call that pain? It is called funicular pain. So that pain is very vague and ill-defined. So why do you get muscle pain in such a case? What are the causes for muscle pain?
Can be viral myositis.
Okay, then anything else?
Dermatomyositis.
Okay. Suppose you have an
inflammatory vasculitis pain.
Okay, but more common condition. You are presenting like a case of AFP, no?
Yes,
what is
madam.
the historical condition which produces AFP?
Poliomyelitis.
Poliomyelitis. Do you get pain in poliomyelitis?
Yes, madam. Muscle pain is predominant in poliomyelitis. Even though it affects the anterior horn cell, there can be muscle pain.
Okay, so there can be trophic effect, and then there can be muscle pain and severe pain on handling the muscles also. So even in anterior horn cell disease, we can have pain. Even if it is a viral, it is called as a viral myelitis. Now we use the term acute flaccid myelitis. Acute flaccid myelitis means the anterior horn cells are involved because of the viral infection. So that these things can be the cause for pain. So irritability in a very small, in children less than 6 years, irritability and inability to bear weight or refusal to bear weight can be a manifestation of neurological weakness or neurological pain in children. So GBS may present like that, okay? Or even acute flaccid myelitis, the children may refuse to move the limbs because of the pain. Okay, what was the next symptom that you told?
Unable to walk for 4 days.
So inability to walk, and then it progressed, right? So
yes,
you told initially there was difficulty in. What were the difficulties? Can you?
Initially, the patient complains of difficulty in walking, mainly slipping of chapel while walking, buckling of knees were there, and also difficulty in sitting. Then gradually it progressed to upper limb. There is difficulty in buttoning the shirt, unable to lift the teacup, and difficulty in lifting the hand above the head. Okay. And also difficulty in getting
lower limb. The lower limb bilateral. Right?
Bilateral.
And then it progressed to more proximal joints also. Yes, and then it involved the upper limb.
Upper limb, sir.
Okay. And then there was difficulty in
getting from lying down position.
Okay. And what else was there?
And also there will be also the child complains of slurring of speech, reduced facial expression, drooling of saliva, and also difficulty in drinking water.
Okay.
Bulbar involvement is also there.
Drinking water, bulbar involvement.
Facial.
So how can you explain all these things in some area? Next, in your negative history, you said there is no difficulty in swallowing. Is it not? You
Yes,
said there
madam.
is no difficulty in swallowing. And then you have also written that there is no deviation of angle of mouth. So how do you explain all those things?
Difficulty, there is no, because the both bilateral facial nerve is involved, so there is no deviation of angle of mouth, and
Very good.
9th and 10th cranial nerves are intact, so there is no difficulty in swallowing.
Then why is there drooling?
Drooling is mainly due to facial muscle weakness.
So what
The
happens?
child is not able to hold the water in the mouth.
So which muscle is affected? Why the child is not able to hold? Which muscle is weak? To close
Facial,
your mouth, which muscle is
orbicularis
needed?
oris, madam.
Orbicularis or
Oris.
orbicularis oris, correct. Orbicularis oris. And what else? So whenever there is a facial weakness, because the facial muscles are weak, buccinator is weak, the food and the saliva can collect in the vestibule or in the sides of the cheek and then inside the cheek. And then when they open the mouth, when they cannot close the lips tightly, and when they are trying to swallow or chew, there can be incoordination because the muscles are not weak rather. And then because they cannot get the speed and swallow, the saliva can come out because the orbicularis oris is weak. What is the other usual history that we get in children? Especially spitting out in the morning when they brush the teeth, when they try to spit out, the spitting out again is difficult because, so these are some of the history. And again, small children, if you ask whether they can drink using straw, drinking with straw is difficult. And you have also mentioned that he is keeping the eyes open, right? While
Yes, madam.
sleeping. So all these things indicate that probably it is because of the facial weakness. But at the same time, you said there is no change in the voice, no nasal regurgitation, and the child can swallow food. So probably at this stage, we think that mainly it is a facial now, but we cannot be sure. We are at the history level only. We have to keep everything open and then examine the child whether there is any palatal involvement or weakness, because the child has tendency to drinking water is also difficult for the child. So we have to again see whether the palatal weakness is there or 12th nerve weakness is there. Is there any difficulty in coordinating between chewing, swallowing, etc., etc. Okay.
Yes, madam.
Okay. Carry on. In your negative history, you mention anything about like whether the child has any sensory symptoms or whether there is a band-like sensation?
There is no history of numbness, tingling, blurring of vision, burning sensation, paresthesia, anesthesia.
Okay. Is there any something like a band-like sensations or some feeling of tightness anywhere in the body?
No, madam.
So what is the significance of that?
In transverse myelitis, there is a band-like sensation.
There is a spinal cord involvement. You can get a band-like sensation
band-like.
over. That is very important. It means that there is a level for that lesion. So it indicates a spinal cord involvement. Okay. Okay. Senior faculty members can also contribute. I have just asked a few questions. If others can ask at this level, we will then move on to the.
Just one point, Maxine. Negative history is too much. So only relevant negative history. So you can break that negative history into two. Any neurological condition, we are going forward with answering different questions. Is there a neurological problem? Where is the problem? What is the pathological basis? There are most important thing. So out of which the history points which are helpful in the anatomical localization definitely are important. In that stage, the negative points for the pathological conditions need not be mentioned.
Yes, sir.
That that group of negative points you can bring into the past history.
Yes, madam.
So in the history of presenting illness, the onset, evolution, and the present status of the case is very important. In this case, when there is a bilateral involvement, how fast from the onset to the peak. So there are many points which are needed for the prognostication also. So that a few of those points are important. And as you said, lot of points for the localization. And the pathological thing, you can take it, the past history of you thought of many under things, poisonings, many things. Those things better mentioned in the past history rather than both mixing up. Okay. Next thing is, few of the points were contradicting. When you mentioned about the swallowing part, that should be, or clarity should be there. Whether it is, as Dr. Mini said, there is a possibility of chewing and the food particles coming out when the facial weakness, and very closely thing is the swallowing. So that need to be differentiated. When you are chewing, the solid particles are going outside, argues more for a facial weakness. The problem when it happens when the swallowing, liquid diet especially. So when we were we are having poliomyelitis cases, we were considering this point, whether it is a cranial polio, spinal polio, craniospinal polio. So these points were important. Is there anything suggestive of the lower cranial nerve involvement, especially the swallowing of fluid, or is it planned swallowing? So that is very, very important prognostically in this case also. In a case like facial palsy, you need not mention no deviation, because what you expect in this case is a bilateral facial palsy. There, as Dr. Mini pointed out, what you need to ask is whether there is a difficulty in using the straw, whistling, blowing, like that, rather than a deviation to one side. Deviation is one side occurs when there is a one-sided pathology. Bilateral pathology, it will not be there. So your negative history list need to be modified. It should be Mini, you continue, Mini.
കണ്ടിന്യൂ ചെയ്യാം സർ. ഞാൻ എൻ്റെ ഇടയിൽ ഹെഡ്സെറ്റ് ഒന്ന് റെഡിയാക്കാൻ പോയിരിക്കായിരുന്നു. മോഹൻദാസ് ഓളയും കുറവാണെന്ന് പറഞ്ഞുകൊണ്ട്. ഓക്കെ, യു ക്യാൻ കണ്ടിന്യൂ.
Okay, madam. General examination. Child is alert, conscious, oriented. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals, pulse rate of 92 per minute. Regular rhythm, normal volume. All peripheral pulses felt. No radial or radiofemoral delay. Capillary refill time less than 2 seconds. Temperature 98.6. BP 94/64 at right arm. Sitting position. No postural hypotension. Respiratory rate 26 per minute. Normal breathing pattern. Saturation 99% in room air. Head to foot examination. Head appears normal. Hair, no alopecia, friable hair. Eyes, unable to close both eyes. No corneal opacity, conjunctival cirrhosis or bitoid spot. Oral cavity, drooling of saliva present. No cheilitis or oral ulcers. Limbs, no contractures. Nails, normal. No bed sore. No bite mark or scar. No rash or vesicle. No muscle tenderness. No neurocutaneous markers. Skull and spine, normal. No gibbous or spinal tenderness. No knuckle pigmentation. No signs of vitamin deficiency. No nerve thickness. Anthropometry, weight 8, observed weight is 18, expected is 19.
Actually, one point, you go back to the vitals. In this case, very important about the pulse rate rhythm, very important, because autonomic disturbances we are very much important in this case with or bad prognostic factors. And there again, other autonomic phenomena you need to check for in the general examination, like what are the autonomic?
Postural hypotension can present. There will be excessive sweating. Then flushing is there. Tachycardia, arrhythmia.
Okay. The tachycardia, arrhythmia, irregularity will be not at one point of time, only on follow-up you will get. Other things are flushing, sweating problems, temperature variation, all these things are important. And one thing, you need not mention too much of contracture, bed sores and all in this case, because it's only for a so you limit the thing to not too much of unnecessary things need not be mentioned here. So what you are missing is there is a possibility of some of the drug-induced and drugs and toxins, especially heavy metals. So in the case, you need to mention in the past history also whether they are on some drugs in the Ayush things or Ayurvedic, homeo or heavy metal, basmums and all. So that is important in the past history. And the stigma in the general examination due to those drugs and toxins that are important. So pathological basis. So in the examination, your anatomically localization, pathological basis, this comes a very, very important thing. You are answering what is the pathological basis is basically from the general examination, clues for the pathology. So is it due to an infection? Is it due to demyelination? Is it due to vasculitis? Is it due to heavy metal poisoning? All the categories of the pathology you tell based on the general examination. Okay. So all the points. Okay, go ahead.
Excellent. Can I ask you one question? Am I audible now?
Yes, madam.
Okay. So you mentioned that there is no postural hypotension, and your patient is bed-bound, right? Lying in bed because of the weakness, right?
Yes, madam.
So did you actually check the BP for postural hypotension? How do you examine for postural hypotension?
By lifting the bed couch, madam, in sitting position.
Actually, in this child, it is going to be very difficult. So postural hypotension, when somebody has a postural hypotension, when they are getting up and all, they get a feeling of giddiness and they tend to have a blackout like things. But examination wise, how to look for it is the patient should be in the supine position minimum 30 minutes before you start examining for postural hypotension. They have to be flat for 30 minutes at least before you start for examining. You tie the cuff at that time and then you make the patient stand up. And within 1 to 3 minutes of standing, you have to check the BP, right? So that is how you look for the postural hypotension. In this case, because the patient is already bedbound, it may not be possible for you to elicit the postural hypotension, but there can be labile hypertension. The BP can fluctuate from time to time in a patient with GBS. It can shoot up at any time and it can also drop at any time. So if you use any antihypertensives for hypertension in a patient with GBS, you have to be very, very cautious. You have to use drugs which are short acting actually. Otherwise, if you use longer acting, patient may then after some time go into a hypotension state and you will find it difficult to manage. So this labile hypertension is one thing that you can get in GBS. Okay. Okay, carry on.
1 minute, Maxim. In this case, general examination, you need to describe the attitude and posture of the patient because from what you said, the pattern and topography of the weakness is lower limb, trunk, neck, upper limb, and including the lower brainstem involvement is there. Okay. And in that case, you need to mention about the attitude. Second thing, the mentioning about the breathing is not enough. It's not enough to say that the rate and the pattern. A little more is needed because pattern regularity is not the thing. What is the involvement of different parts of the, because what is the involvement of the intercostal? What is the involvement of the diaphragm? What is the depth of the breathing? And the speech also. See, what is the amplitude on voice? So we need to talk to the patient and see one time the amplitude of the speech. Second thing, when you narrate something, whether it is declining, because you need not be jumping into the conclusion that it is a Guillain-Barré, because other entities also need to be considered. Maybe 95% it may be a demyelination GBS type, but 5% possibilities other conditions also, out of which binaural junction disorders can be there, myositis can be there. So how can you differentiate that? It is the fatiguing, what is happening to the weakness on activity. So each and every point is needed in the history part and in the evaluation also. There can be a possibility of binaural junction disorders also. Speech evaluation, especially the amplitude and what happens on continued speech. Those are important. Okay.
Anthropometry, observed weight is 80 kg, expected is 19, at 58th centile, height is 114, expected is 110, between 50th and 75th centile, head circumference is 51, BMI is 13.9, between 25th and 50th centile. Coming to nervous system examination, higher mental function, child is right-handed, conscious, interacting well, oriented to time, place, person, memory, immediate intact, recent intact, and remote memory intact, slurring of speech present, attention and calculation could not be assessed, intelligence could not be assessed. Cranial nerve examination, olfactory nerve, normal, no anosmia, parosmia. Optic nerve, bilateral pupils equal, round, regular, reacting to light. Visual acuity, distant, near vision normal, color vision normal, field of vision normal. Fundus examination normal. Third, 3, 4, and 6 cranial nerves, no ptosis, skin, nystagmus, extraocular movement full and equal in all directions, pupils bilateral 3 mm, light reflex present, both eyes, accommodation reflex present. Trigeminal nerve, sensory normal, motor, no deviation of jaw, no temporal hollowing, muscles of mastication normal, jaw jerk absent. Coming to facial nerve, wrinkling of forehead absent bilaterally.
Here again, go back to the cranials. Cranials, all these are very, very important in this case. It's the visual part you said a second nerve. The second thing is the oculomotor movement, 3, 4, 6 part. And fifth also, we need to check that fifth. Fifth, it's not enough to say there is no deviation of jaw, because there can be a subtle involvement of the, especially when you are getting evidence of the bilateral sabandha weakness, you need to test about the fifth in different ways, especially the minimal motor weakness. It's not enough to say there is no deviation of jaw. You don't expect the deviation of jaw. So how can you test that the power of the motor part of the temporary, the fifth?
Ask the child to deviate the jaw to one side and apply resistance on the opposite direction.
Simple question you ask, a simple thing you can offer something to bite and chew. Okay.
Okay.
Oh, what is the most important difficulty when there is a motor weakness?
Difficulty in chewing.
Simple groundnut you can offer. In this case, it's not it should not be done because of the following problem. Something you see how it is affected. Okay. How can you in the context of a facial weakness, how can you say there is a deviation problem? Jaw deviation and a facial deviation. In this case, it may not be a problem when you are getting a bilateral weakness. When there is a unilateral facial weakness, how can you look for the motor involvement of the fifth?
In
difficult or
in trigeminal weakness, weakness, if there is left-sided trigeminal nerve weakness, the deviation is to the paralyzed side.
will you make out, especially when there is a unilateral facial weakness also? That's a difficulty. When there is a facial weakness, it may lead to confusion in the decision. So what should be, where should we look for to decide about the deviation of the jaw? Where will you be looking? At the teeth, incisor, teeth, okay?
Okay, sir.
And you are biting, this is the corresponding. When there is a, yeah, this case, bilateral. So the to do is to assess the chewing power of a bite. Okay.
Maxine, how do you formally test the fifth nerve motor? What are the tests that you do? You ask them to clench the teeth, no?
Yes, yes,
And
ma'am.
then you palpate over the masseter.
Masseter.
That is the most important formal test for testing the masseteric muscles. Then the pterygoids only, when you are testing the pterygoids only, you are looking for the jaw deviation. And as Sir told, when facial nerve is involved, it is the deviation of the angle of mouth, especially unilateral, as Sir told, deviation of the angle of mouth. So there can be an apparent feeling that the jaw is also deviated, in which case you have to look at the lower incisors to see whether that is in the midline or it is deviated to side. That is how you look for jaw deviation. Okay. So whenever you are asked how to test for motor fifth masseter, you have to palpate the masseter, ask them to clench the teeth and palpate the masseter, and that has to be highlighted. Along with the pterygoids, that has to be seen. And also temporalis region. Temporalis hollowing and temporalis also, when you are just clenching the teeth, you can see the, you can feel the muscle actually. Okay. Okay.
In a case
And
like
can Georgia normally absent or is it pathologically absent in this case?
Georges can normally it can be present or absent.
Sometimes may be difficult to elicit. Okay. Okay.
in this case, you should limit the negative points just continuing like that. See, in the motor, you said no temporal hollowing. Actually, that's not relevant here at all. So better restrict or limit your negative points with the relevance only. When you are dealing with the case of 1 week duration, you don't expect not temporal hollowing and all. So that can be avoided.
Okay, sir.
That become relevant when it is of a little longer duration where you are considering a myopathy situation. Okay. A longer duration, the temporal hollowing, all these things and a peculiar facies all becomes relevant. In a 5 days or 1 week problems, it's a different group of conditions, maybe neural, radical, maybe minor junction or muscles, myositis also, but don't expect the wasting. So the hollowing is based on the duration only you need to mention. In this case, it's not relevant. So you could have avoided that. Okay.
Okay, sir.
Sir, one thing I would like to highlight, in case of acute paralysis also, if it is a severe axonal paralysis, you can see wasting within 2 to 3 weeks itself can set in. That is a classical, so classical in GBS. If it is an axonal pathology, the wasting sets in quite early. And that is a negative point also, that is very difficult for the patient to recover from that. Unlike a demyelination where you don't get any wasting. In demyelination, there is actually severe weakness, but you don't get wasting. Clinical clue is whenever there is a wasting, acute onset wasting in a patient like this, you have to think of axonal pathology. So in axonal conditions, you can get wasting in acute setting, but not, sir, as sir told, not over the temporalis and all, it is over the limbs that you come across. Severe wasting can occur within a few weeks or 1 or 2 weeks itself. That is possible in GBS. Okay, carry on. Maxley?
Yes, madam.
Cranial one more point in the cranial territory you need to mention was about the lower pharyngeal. That you're coming to that?
Yes, sir. I read only up to facial nerve.
Facial. Then go ahead. Go ahead.
Facial nerve, wrinkling of forehead absent bilateral, inability to close bilateral eyes, Bell's phenomena present, bilateral nasolabial fold absent, difficulty in smiling, no deviation of angle of mouth, drooling of saliva present, not able to blow. Vestibulocochlear nerve, hearing normal, 9 and 10.
Important point you mentioned here, because we were in doubt during your history whether the drooling outside was due to facial weakness only, or whether there was a swallowing problem. At this stage, you have moved a little ahead. There is a pooling of saliva in the throat. That's what you mentioned. It's
Yes,
not between the teeth and the cheeks. Is it there, or is the collection of the saliva in the pharynx? So that's very important, because that indicates there's a swallowing difficulty. So that indicates 9, 10 also is a weakness and a coordination problem that carries more of a bad prognostic thing. So all these things are important. You need to stress on all these things. Lower cranial nerves, apart from the facial also is 9, 10 also there is a problem. Okay.
Glossopharyngeal and vagus nerve, no nasal regurgitation, no nasal tag of voice, uvula is midline, bilateral palatal movement equal, gag reflex present.
So here again, it's not it's not a deviation. So when you're expecting a vagal involvement or a bilateral weakness, it's not the deviation. So what happens about the whole palate? How much is the raising? What is the shape of the palate? That's important, because when it's a unilateral weakness, what is happening? One side. When there's a bilateral weakness, the elevation and the side of the palate. So full power is there. This will be the shape of the palate elevation. The other thing is a minimal elevation. So bilateral weakness occur is more important nasal quality of the sound and the swallowing difficulties, water coming out. All are important. In this case, there is a chance of the involvement of 10th is there.
Yes, sir.
Mini, you agree or disagree, Mini? That part?
Yes, sir, because she told, is there a pooling of saliva you told?
No, sir. Drooling of saliva.
Drooling only, no pooling. So you mean to say that the palatal movements were normal? When you are asking, how do you test the palatal movements?
By using a tongue depressor, you please by using tongue depressor, either touch the posterior aspect of the tongue or in the posterior pharynx.
That is for the reflex movements, but voluntary?
Tell the patient to say ah.
So it is not ah, it is ha, H-A, ha. So when the patient, people always ask them to say ah, it is not ah, you have to say, ask them to say ha. When they pronounce that, usually you can see the very good movement of the palate. So ask them to say ha instead of ah, okay? So the palatal movements, you have to observe whether, as sir told, whether they are equal on both sides, and not only whether they are equal, whether they are normal appearing. The level of normalcy and all is from your experience, seeing how the palate moves. So if bilateral weakness is there, and when there is only a minimal movement, you'll have to say that the movement is minimal. So I assume that the movement was normal. Is it not, Varghese? Varghese, movement was normal, no?
Yes, ma'am. The movement was normal, ma'am. The palatal movement was normal.
So from your history, what I understand is that there is no 9 or 10 cranial nerve palsy. But if there is a pooling of secretion and pooling of secretion, saliva in the throat, then you have to be careful. Or if there is a decrease in the volume of speech or tendency to choke or cough while child is swallowing, that is also very important. You just give fluids and see whether the child is able to swallow. If the child is having coughing, again, the chance that there is a lack of coordination while trying to swallow is there. So when there is a subtle involvement of the 9 and 10 cranial nerve itself, you should pick it up, because as sir told, it has got a very serious implication, because these are the kind of patients whom you want to manage in ICU settings, right?
Yes,
Not in the general ward. Okay, carry on.
Spinal accessory, turning of head to side normal, shrugging of shoulder normal, hypoglossal nerve, no deviation of tongue, no fasciculation, atrophy or spastic tongue, power of tongue normal. Motor nerve, motor system, bulk, equal and comparable both sides, tone, hypotonia in all four limbs.
Actually, one point. In the history, you said there was a slurring of the speech. I have noticed that. You mentioned a slurring of the speech. Okay. Now, from what you are describing, what may be the reason for the slurring of the speech?
The child had difficulty in articulation of words due to facial muscle weakness.
How can you differentiate this thing from what you described? What may be causing the slurring of the speech? And what type of a speech problem is likely? Slurring is a vague term. It's okay.
Mainly dysarthria type.
LMN, is it UMN? That is what sir is asking. How do you know whether it is a LMN or a UMN involvement, whether it is a palatal involvement, whether it is a more anterior involvement of the tongue?
If it is a palatal involvement, there will be nasal tag of voice is present, and also change in voice sound also will be decreased.
Okay.
But in this case, the sound is normal, no nasal tag.
So, in this case, when there is a lower motor weakness, when there is a speech problem, what all ways it can occur? First thing I said, the low amplitude, that is, the power is less. Overall power in the wind is less, so low amplitude. Second thing is, there can be weakness of these three group of things. One is the palate, other is the tongue, other is the lips. Okay. So that is why you are looking for this thing. As you said, if the palate is involved, the nasal tongue to the voice, other things, the change in the voice in that nasal quality, the physics of the sound will be altered. So one thing is the intensity of the sound, the other is the change in the physics of the sound due to nasal quality. The next two things are whether it is the tongue or the lips. So you make her talk. Papa, baba, ma, tata, dada, na, kaka, gaga, nga. Okay, 5-year-old child. Which will be affected in this case? Most likely, what will be the problem?
Papa is
yes, ABLs are most likely. So you ask her to pronounce papa, baba, ma, ha, ba. Okay, so those will be affected if the slurring or whatever you are talking is. The slurring is a big term. In this case, if the tongue is normal, it's very unlikely the slurring part. It's not the UMN, it's not the LMN of the tongue. Okay. Tata, dada, na, sa, sha, sha. None of them are likely to be affected if the tongue is normal. Okay. So facial bilaterally affected. What way the speech is likely to be affected is either the volume of the speech is less or the papa, baba, ma labials are affected. So the speech part also is important in this case of weakness. Okay.
Okay. Then coming to the power, neck flexion, extension weak, both left, neck flexion, extension weak, shoulder flexion, extension, abductors and adductors are less than 3/5 on right and left is 3/5. Elbow flexors, extensors 3/5 left and right. Finger grip, bilateral hand grip weak, hip flexors, extensors, adductors and abductors is less than 3/5 in both right and left. Knee flexors and extensors are 3. In flexors is 3/5 and extensors is 2/5. Angle, dorsiflexion, plantar flexion, inversion, eversion is 3/5 on both right and left. And trunk, he was not able to sit with support.
Before the power, did you mention about the tone?
Yes, sir.
Yes, sir.
Hypotony in all four limbs.
I didn't notice. Okay, yeah, go ahead. Okay.
So from your examination of power, what is your comment? What kind of a weakness is there?
muscle weakness mainly, the power is low, mainly the muscles are affected.
No, what I meant was whether it is proximal, distal, both are involved.
Proximal muscles are more affected than distal muscles.
Okay.
From where grading, that's not, that is one very important thing. You go back to this thing. All are
three എന്നാണ് പറഞ്ഞത്. എല്ലാം 3 ആണ് പറഞ്ഞത്. ഏതോ ഒരെണ്ണം മാത്രം 2 പറഞ്ഞു. Extensor.
Important thing. It's not this grading. There is an importance to the grading. It's not merely enough to move on. So we need to tell, because diagnostic utility is there. Where all is the topography of the weakness? What is the pattern of weakness? Is it more in the lower limb compared to the upper limb? In the lower limb and upper limb, is it proximal versus distal? Is there an asymmetry about the power of the trunk, power of the neck, and the respiratory muscles? All these things in sequence you need to tell. So from here, it's everything is 3 by 5.
Almost same.
Okay. Extensors of the knee only is too weak. That's what you said, proximal weakness. But the hip is having 3 power.
Less than 3.
Okay. So almost like proximal as well as distal. That is what I understood. Both proximal and distal are involved, and also between the sides, left and right, there is not much asymmetry. Right?
Yes, madam.
Okay. പുരുഷോത്തമൻ സർ അങ്ങനെയല്ലേ മനസ്സിലാവുന്നത് ഇത് കണ്ടിട്ട്?
Actually തന്നെ പറയാലോ 2 by 5 ആണെങ്കിൽ 2 by 5. Okay. In this thing, less than 3 by 5, less than 3 by 5. Rather than that, you can tell if you think it is 2, okay. It should be 2 or 3 or whatever. That's why you're grading. Okay.
Because it is very important to grade the power daily progress of GBS. We have to grade the power properly. So if there is only a flicker of movement, you have to mention that. Next day, the child may be moving in bed a bit more. So this is how you assess the GBS patient. Daily, you have to have the motor power examination bedside. So you have to specifically mention what exactly is the grading, rather than saying less than 3. You may be say it may be 2, or it may be just a flicker of movement or no movement at all even. So less than 3 doesn't tell exactly what you mean as told. Okay. Carry on.
You need to answer the parent's question regarding whether my child is improving, what is the chance of my child walking, and all these things. There are different scoring system and all. So this is MRC scoring. So this is very important in the overall scoring to prognosticate and the communicating with the parent. All these things are important. That's why. Okay, go ahead.
Then coming to superficial reflex, conjunctival and corneal reflex absent, right and left. Cremasteric reflex present. Abdominal reflex present. Plantar flexors. And deep tender reflex, jaw jerk, biceps, triceps, supinator and knee jerk, ankle jerk, all are absent. Sensory system.
So there is generalized areflexia, right?
Areflexia, madam.
Okay.
Sensory system able to perceive touch, pain, temperature, difference in all dermatome, proprioception and vibration intact. Cortical sensations are intact. Cerebellar signs, no nystagmus, no ataxia, gait independent walking not possible, spine no tenderness, meningeal signs absent, no signs of autonomic instability.
When there is a significant weakness, will you be able to assess the no cerebellar signs?
If the power is less than 3 by 5, cerebellar signs could not be elicited.
So you have to say you haven't examined the cerebellar signs because the child is weak. That should be the way. At least grade 4 power should be there to comment on the cerebellar.
It's difficult to assess the cerebellar signs in the upper limb and lower limb with power of less than 3. Practically, it may not be possible. Okay. From what you said, non-nystagmus, okay, agreed. Nystagmus, dysarthria, those things, but not the other cerebellar signs in the upper limb and lower limb. It may not be possible. Okay. Go ahead.
Then coming to other system, gastrointestinal system, soft, non-tender, no hepatosplenomegaly, no palpable mass, bowel sound present, respiratory system, no vesicular birth sound, normal vesicular birth sound, no added sound, normal breathing pattern, cardiovascular system, S1, S2 normally heard, no murmur. Hello. Then coming to the
Some
summary.
disturbance. There is some disturbance. I think somebody else is talking. Ondas, is it possible to mute the person who is talking?
Mute.
I have muted.
Okay, okay.
Then coming to the summary, 5-year old male child, second born to non-consanguineous married parents, developmentally normal, immunized up to age, with respiratory, with history of respiratory infection 3 weeks back, presented with acute thoracic paralysis, characterized by symmetrical ascending weakness of limbs and trunk, with bilateral facial palsy. On examination, child conscious with signs of flaccid quadriplegia and absent deep tendon reflex with bilateral LM and facial palsy.
Okay. So where do you localize now?
Coming to the clinical localization, first we have to check whether it is a UOMN weakness or LMN. In UOMN weakness, there will be mostly there is spasticity is present in UOMN, and also the reflexes are exaggerated.
No, weakness in UMN. Where is the weakness?
Mainly distal muscle are affected in UOMN.
No, distal muscles are usually affected in UMN, correct. And there is loss of dexterity of hand muscles. And when there is a weakness, usually UMN type of weakness setting in, classically, it is usually
spastic, madam.
Spastic weakness, okay.
Then
and there is no, there will not be acute onset of wasting also in UMN weakness, and the reflexes will be exaggerated. Okay, okay. LMN. Then, this case.
Then in coming to LMN, this case of LMN type of weakness. Then in LMN, we have to localize whether it is in spinal cord, anterior horn cell, nerve root, nerve, or neuromuscular junction. In this case, spinal cord, there is no bladder and bowel involvement is absent, and there is no sensory level. So spinal cord is eliminated. Hello. Hello.
Proceed.
How can you eliminate spinal cord?
In spinal cord, there will be involvement of bowel and bladder, and also there is a sensory level is present in spinal cord lesion.
Suppose you have only anterior horn cell involvement due to a viral myelitis. So you are talking about transverse myelitis. If you are talking about transverse myelitis, I agree. But whenever there is an anterior horn cell involvement, what you have to remember is that there will be only a pure motor paralysis. So this child only no sensory symptoms at all, no?
Pain.
No sensory symptoms at all, no? Signs actually, I mean. Negative sensory. Pain is okay. Pain can occur even when there is anterior horn cell involvement. That's what I told. Apart from that, there is no negative sensory signs as such. So this, based on science, you will have to say that it is pure motor syndrome. So based on that, if you say anterior horn cell involvement, you can have pure motor syndrome without sensory involvement. So just because there is no bowel or bladder involvement, or just because there is no level, you cannot rule out spinal cord involvement. Okay.
Okay, madam. Then coming to nerve root, it can be a possibility because there is symmetry in nerve root. There is symmetrical type of weakness is present, and also
I'm now told there is a possibility of a spinal cord involvement where the anterior horn cell is selectively involved. That was the situation when we were all students, poliomyelitis was one of the commonest of the entity. So it's a spinal cord problem where you get a lesion of anterior on selectively. But the point which differentiate, it's always patchy involvement, here and there involvement. So
Yes,
by symmetrical involvement, that is the point which will differentiate anterior horn cell. All anterior horn cells from top to bottom, from the brainstem up to the lower spinal cord, unlikely. Okay. So.
Okay. Then
an acute flaccid myelitis situation following due to some viral infections, especially in some countries. Okay, proceed.
Okay, coming to nerve root, it can be a possibility because there is asymmetrical type pattern of weakness, and also there is a sensory symptom, that is root pain is present in this case. It can be a possibility. Peripheral nerve is also a possibility, but in peripheral nerve, mainly the distal muscle is involved more than the proximal muscle. Then coming to neuromuscular junction, in neuromuscular junction, there is waxing and waning type of weakness is present, so less likely. And coming to muscle,
in
muscle
neuromuscular junction, usually it is proximal weakness more than the distal weakness, usually. And the involvement of the eye muscles, ocular muscles, extraocular muscles are affected, as well as bulbar muscles, as well as facial muscles can be affected. So here it is more like a bilateral facial weakness and then limb weakness, right?
Yes, madam.
And that is distal and proximal are equally affected. And there is severe pain also. And all the reflexes are absent. So again, that is not in favor of a neuromuscular junction.
Then coming to the muscle, in muscle, the muscle also proximal muscle is more involved, but bulbar involvement is less likely in case of muscle.
Okay, Dr. Kalpana, I think Kalpana madam is around. She had sent some message also. I couldn't read it properly because I'm using my mobile. So if possible, madam can unmute and tell what she was telling. She was saying some points.
It was mentioned like
slides हो गया, 42 slides.
spinal cord. When we are saying spinal cord, it is UMN. That is what I meant.
I didn't hear him, madam.
Because spinal cord is added under LMN. Then AIDS is separately mentioned, but spinal cord, when we say spinal cord, spinal cord is actually part of central nervous system, isn't it?
Yeah. She's ruled out spinal cord, saying that there is no, but even when spinal cord is affected.
No, in the algorithm, under LMN, it is mentioned as spinal cord.
Okay. Yes, she was mentioning the differential diagnosis probably, right? So again, spinal cord, can you have all flaccid paralysis in case of spinal cord involvement?
In case of
with
spinal
absent
shock.
reflexes?
Spinal shock,
So
there is a possibility, madam.
So that should come under UMN.
UMN, madam.
UMN, actually. Okay. Okay, carry on.
Actually, in one point here, in the analysis and localization, you said there is root pain. Okay, actually, in this case, should we consider it as a root pain is debatable, because when there is a root pain, the compression leading to a particular type of pain only will be included in the root pain. You can get this sort of a pain due to hyperanesthesia in many of the cases, like especially when polio was there, we all will be getting, the patient will be highly irritable, will not allow to touch. So they are not root pains. Okay. In situations like this also, there will be some subjective pain due to hyperanesthesia. They are not included in the root pain. It's not selective compression of root involvement or nothing like that.
It may not be compression, sir. It can be inflammation of the roots.
Inflammation.
Irritation and inflammation. Multiple ways can be there for pain. Multiple reasons can be there. One is muscle pain, pain arising from muscle, then from nerve also, and also from radical because of the inflammatory pathology. It need not be compression always.
Complete ആയോ?
ഇല്ല sir, investigation.
അല്ലല്ല, no. Provisional diagnosis in അകത്ത് anatomical localization, pathological, functional. So then only it will be complete before you go ahead with the investigation part.
Anatomical localization may be nerve root or nerve can be a possibility.
Is it root or radicals? രണ്ടും ഒന്നാണോ മിനി?
Polyradicular neuropathy.
റൂട്ട് എന്ന് പറഞ്ഞ nerve root എന്ന് പറയുന്നതിനെ തന്നെയാണ്, അതിന്റെ ഇൻഫ്ലമേഷൻ തന്നെയാണ് റാഡിക്കുലോപ്പതി എന്ന് പറയുന്നത് സാർ.
നമ്മളിപ്പോ പറയുന്നത്. Okay.
But ഈ GBS പോലത്തെ കണ്ടീഷനിൽ there is radiculoneuropathy, polyradiculoneuropathy.
So by my anatomical localization is LMN. In LMN, it is in the nerve root and also in the nerve. So DDs in case of polyradicular neuropathy include mainly GBS because there is history of respiratory infection 3 weeks back or is there. Most probably it is a case of GBS. Other DDs may be. Hello.
Okay.
Carry on.
Other DDs may be Lyme's disease, sarcoidosis, HIV, cytomegalovirus, Coda equinus.
In the diagnostic anatomic localization, most probably in the radicals. Okay. Then the anatomic localization again, it's not only spinal cord, it's a brainstem also is a involved. So anatomy include that much other extent of the lesion. Second thing is the pathological basis, most likely demyelination, peripheral demyelination, and then only most important reason is GBS. Rather than going to that, okay, the anatomical localization, pathological localization, peripheral demyelination, and that is most likely Guillain-Barré, and that too, what type of Guillain-Barré? Guillain-Barré, different types. Okay, there are other types. Okay.
Can you conclude whether it is a demyelination or axonal involvement based on your examination, or is there any clue to say that it is demyelination or axonal based on your examination?
It is mainly AIDP is followed by is caused mainly due to respiratory infection, and AMAN is mainly due to diarrhea disease caused by Campylobacter jejuni.
More than that, from your examination, I asked. So whenever there is a pure axonal involvement alone, axonal kind of GBS like AMAN, where you have motor axonal neuropathy, what we see is that usually there is sometimes the deep tendon reflexes may be preserved rather than being absent. So if the deep tendon reflexes are preserved, you have a pure motor involvement in the same way that you have got acute flaccid paralysis with a retained reflexes. Two things you have to consider is one thing is this AMAN type where there's an axonal involvement, reflexes may be retained. Second is hypokalemia. So these are the two things in the close differential diagnosis which you have to consider. Okay. And rest of it, whether it is an axonal or demyelination, is actually depending upon the other lab findings also. Okay.
Blood investigation, hemoglobin of 14.1, total count of 9,700 with neutrophils of 52, lymphocyte 39, monocyte 7 and eosinophil 1, platelets of 4.8 lakh, ESR 28, CRP 5, sodium of 135 millimoles, potassium 4.6, bicarb 17, chloride 103, calcium 10.5, phosphorus 5.8, creatine 0.4, SGOT 33, SGPT 18, ALP 188. Coming to CSF analysis.
Go back to the previous slide. So in the investigation again, you need to exclude certain possibilities in the differential diagnosis. That's the purpose of this thing. Okay. Here the hemoglobin is normal. So that is a point against many of the heavy metal poisoning situations. Second one, the count is a normal. You need to interpret all these things. Okay. Count is normal. And ESR and CRP part is very important because
Vasculitis.
the inflammatory pathology, you get this thing. Very important there, the CPK also. Okay. Myositis is one of the possibilities where there is a brainstem involvement, the other thing. But you consider that. Okay. About CPK with the ESR CRP. And in the electrolytes, potassium is more important. Okay. So basic investigations, potassium involvement, CPK is important, ESR and CRP is important. Okay.
Coming to CSF analysis, WBC1, RBC1, protein
So
80.
when did you lose the CSF?
At
Which
the end
day of illness?
By about the 8th day of illness.
Second week.
Second week. Child presented the day 7 of illness to our
So
hospital.
what is the importance of planning the CSF study in GBS?
Usually at the end of first week or by second week, the CSF will show albuminocytological dissociation.
Can you get normal CSF by second week in GBS? In some cases, in some 10 to 30% of cases of GBS, the albuminocytological dissociation or the protein elevation need not be seen. So just because a CSF study in the second week is normal doesn't rule out a GBS. That is what I meant. If it is present, well and good. Okay. Okay.
Then MRI brain showed patchy meningeal thickness with enhancement involving the free edges of tentorium cerebral and bilateral seventh nerve. MRI spine thickening with enhancement in the multiple cauda nerve root. This is the enhancement in the seventh cranial nerve and also in the spinal cord.
Is it pachymeningitis or is it a root involvement? Varghese?
It's a root involvement, ma'am. The enhancement of the root, ma'am.
Okay. So is it possible to get enhancement of root, Maxilin? Is it in favor of GBS or not? Or is it against GBS? Maxilin?
It is nerve root enhancement is not seen. It is less likely of GBS.
It is very much in favor of GBS actually. You can get a nerve root involvement in GBS, especially in the cauda region. You can have a nerve root involvement. Also, cranial nerves also there can be involvement. The commonest involvement of the cranial nerve mentioned in GBS, because Varghese told that there is a facial nerve root enhancement. I just checked. So I saw that it was a third nerve as well as 7th, 5th, and 9th and 10th. All the nerve roots can get enhanced in cases of GBS. Only thing is that we don't usually take MRI for GBS cases. Why did you take an MRI of the brain in this case? What was the indication to do an MRI of the brain in this case?
The child has initially had irritability. There can be and Adam can be also encephalitis picture.
So, but then in Adam, what is the usual finding in MRI? Spine?
Enhancement of spine can.
I agree with you, because there was a irritability in the initial period and then there was a weakness, maybe for central and peripheral demyelination. It can coexist, and there is no harm in checking for MRI in such a cases, because you sometimes come across central and peripheral demyelination cases, but in this case, classically it is a GBS-like presentation. So usually,
ma'am, as initially the child had a localization towards the brainstem, we did an MRI.
localization towards the brainstem, it is only element facial palsy, no, bilateral.
Yeah.
Bilateral element palsy with the acute flaccid paralysis. It's classical of GBS.
Yeah.
Okay. Okay.
Rule out G.
I understood, because there is irritability and then this initial stage, you might have done the MRI brain and understand. But otherwise, because we usually don't do the MRI brain, we don't usually come across the changes of, we don't usually see these things, because usual described one is the nerve conduction study findings and all, because it is not usually done. That is why we don't see these also. The spinal cord root involvement we come see, because we always screen. Sometimes when you are in doubt, especially when there is a transient bladder symptoms and all, when the plantas are mute and when you have confusion, at that time usually you go for a MRI of the spine also. Initial stages, the nerve conduction studies can also be normal. So in that case, for seeing whether there is a spinal cord involvement, whether there is an anterior horn cell involvement, or whether there is a transverse myelitis, or you may do a MRI of the spine. But usually we don't use, you do a MRI of the brain in classical GBS. And because in this case we could pick up the finding. This is classically described in GBS actually. Okay.
Then,
Okay, go ahead.
Nerve conduction study showed electrophysiology study consists of
Again, nerve conduction study, when you say, you have to mention the day. It's very important. The early stages of GBS, the nerve conduction study can be absolutely normal.
It is done
So
in the
when was it done?
second week of illness, madam.
Okay.
Showed nerve conduction study showed axonal and demyelinating predominantly motor polyradicular neuropathy with both upper limb and lower limb involvement.
So how do you say whether it is axonal or demyelinating?
In
what all parameters are you checked?
In demyelinating pattern, there will be prolonged latency is present, and prolongation of F wave, and also absent H reflex.
No, when there is a demyelination, there is a prolongation of the distal latencies. Latencies get prolonged, and also conduction velocities are very much reduced. Very much reduced. There can be conduction block. That is when you are checking the amplitude. When you are stimulating a particular nerve proximally and distally, and then you are recording from the muscle which is being supplied by that nerve. So all the you are ensuring while stimulating the nerve that all the muscle fibers will be stimulated. That is called as a supramaximal stimulation. We use a current such that all the muscle fibers get stimulated. So you get a CMAP, what is called as a compound muscle action potential, which is because of the because action potential arising from all the muscle fibers. It is compounded or it is summated. So then when you do it in distal, you get a one CMAP, and when you do proximal, you get another CMAP. So when you compare between the distal and proximal CMAP, there should not be more than 10% difference between these two. 10% is physiological that can occur. Proximal CMAP is actually slightly less than distal CMAP normally. But in cases of GBS, when there is a demyelination, there can be sometimes no CMAP elicitable. It could be because of the axonal cause, or could be because of the demyelination with a complete conduction block, or it could be because of a partial conduction block, when there can be some at least 50% reduction between the proximal drop in the conduction, the CMAP amplitude. Actually, the amplitude of the CMAP proximally, there may be a 50% drop compared to the distal. So that indicates again a conduction block. And there is something called as a temporal dispersion also. The duration of that CMAP gets prolonged. All these things you can understand if you see the waveforms in the while doing the nerve conduction study. You have to just go back and see the waveforms, and then you can find out whether there is a dispersion over time. So that means there is temporal dispersion in time. So the duration of the CMAP can get prolonged, and the CMAP itself, there can be a drop in the proximal CMAP, which is called as a conduction block, and there is significant drop in the conduction velocity, and distal latencies. Whereas in case of a purely axonal form of a GBS, the latencies and the conduction velocities are not affected to that extent, but it is predominantly the CMAP which is affected. CMAP, the amplitude is drastically reduced, both proximal as well as distal can get reduced in when there is an axonal pathology. Then there is a mixture of all these things, you call it as a axonal, combined axonal and demyelination. Initially, the predominant pathology may be demyelinating, but as weeks go by, if the patient is not recovering, we can have axonal, secondary axonal changes. And initially, sometimes it may be purely axonal. And as time passes, because the axons are degenerating, there can be secondary demyelination also. And you have to test both the sensory as well as motor nerves also to see whether it is a purely sensory form or whether it is sensory and motor involvement or purely motor. Okay. So what is in this? You said both
axon and demyelinating predominantly motor, polyradical.
Motor. Sensory is completely spared in this case. Sensory conduction was normal.
Sensory. No, sensory is also involved, ma'am. It's not elicitable.
Okay, not elicitable. Eh? Okay, so sensory motor polyradiculoneuropathy. F and H are also affected. Okay. Okay.
Then
carry on.
Then after giving IVIG, the power of the muscle after giving IVIG, the power improved of shoulder, neck flexion, extension good, shoulder, shoulder is more than 3/5, elbow also 3/5, wrist 3/5, hand grip good, hip 3/5, knee 3/5, and angle 4-/5. And at the time
so what is the indication? What is the indication for giving IVIG?
Because there is bulbar muscle weakness is there, and also rapid progression of symptoms, quadriplegia.
Okay. So when there is a respiratory muscle involvement, when there is a bulbar weakness, when there is a rapid progression, or if the person is not able to ambulate independently for 10 meters, that is in adults that we take usually, those are the indications where you are giving IVIG. Very subtle weakness. Even if you don't give IVIG, the patients may improve. But IVIG prevents further progression of the disease. Actually, whatever weakness has occurred, it takes time to improve because the antibody is bound to the nerve. It has to get removed for the patient to recover. So the moment you give IVIG, don't expect that the patient is going to improve. It stabilizes the disease actually and prevents the antibodies from binding to more and more nerves, causing more and more weakness, progression of the weakness. So IVIG actually stabilizes the disease by preventing the progression initially, but during natural course of time, the patient recovers when the bound antibodies are removed. So don't expect that IVIG will immediately produce a relief in patients with GBS. So it takes time. Okay, carry on.
And at the time of discharge, that is after 2 weeks, the right and left neck, shoulder is 4+/5, neck flexion and extension good, elbow 4+, and wrist also 4+, hand grip group good, and hip knee angle is also 4+ in both right and left limbs.
Okay. Any other thing you have to do when you see an acute flaccid paralysis in the investigations? Even if your diagnosis is GBS, is there anything that has to be compulsorily done when you see an acute flaccid paralysis case?
AFP surveillance, madam.
So have you, okay. So have you done that?
Yes, sir. Yes, madam. It was negative.
Okay. So apart from IVIG, what other treatment options are there?
We can give plasmapheresis, madam.
Okay.
200.
Okay. Purushothaman sir, Kalpana madam. Other faculty?
How was the, Maxine, how was the given IVIG 400 milligram per kg into 5 days or 1 or 2 days?
Sir, 1 gram per kg into 2 days, sir.
Okay.
Sir, it's actually given 2 gram per kg over 5 days.
Over 5 days.
2
Because
gram divided over 5 days.
400 milligram per kg per day. Okay.
there is a debate because it's not
Yeah,
like
yeah, yes.
Kawasaki will be giving 2 gram per kg, taking 12 hours on single day. But there are views that it should be better in a spaced manner in the case of GBS. Well discussed. I don't have much to add, Mini. All discussed during the discussion.
Kalpana madam.
It's mostly all of the points I
child
mentioned,
comes-
but the intercostal and diaphragmatic weakness you can mention separately also if it is there or not, because that is very important. And also regarding the power, this less than 3/5, more than 3/5, that is not correct one. You can say either
I
3, 4,
told her
4,
actually,
4, 1.
exact,
That is the thing.
exact power statement should be there for GBS because daily we have to have a muscle power chart for when you are managing a child with GBS because you are looking for the, even if there is a subtle improvement, you are very happy. Patient has started improving. So what is the usual natural cause of GBS? Parents are asking, what will happen to my child? So how will you explain? Maximally?
It is mainly ascending type of weakness, madam. And also involvement of the.
How long it can progress?
It can progress up to
treated,
2 weeks. 2 weeks it become a nadir, and there will be, and thereafter it stabilizes.
So 2 to 4 weeks. It can progress up to 2 to 4 weeks. Maximum 4 weeks.
Wow.
Okay. If it is progressing beyond 4 weeks, you have to have another diagnosis like CIDP or other conditions. Suppose it's a very hyperacute presentation. Within 24 hours, the patient has flaccid paralysis. So can GBS occur like that, or do you have another differential diagnosis if there is a hyperacute presentation?
Consider other diagnoses like stroke.
What stroke? For all 4
dense internal capsule stroke. Dense
internal capsule stroke for quadriplegia. Patient will be comatose.
Okay.
So it is actually a spinal cord injury itself. Hyperacute, if you have a whiplash injury, traumatic injury of the spinal cord, or if there is a spinal artery infarction, anterior spinal artery infarction, there can be motor weakness. So it can come in all on a sudden. So vascular event involving the spinal cord itself. You need not go to the central nervous system to or the brain to explain that. It can be the anterior spinal artery involvement. It can cause a sudden acute quadriparesis. We have seen several such cases while managing. So it's a very close differential diagnosis. Hyperacute onset and maximum weakness occurring within 24 hours. Within a few minutes to hours, the patient may go into weakness. So in that case, you have to consider the possibility of a trauma or anterior spinal artery involvement also. So if you can get sometimes in hyperacute presentation in GBS also, but these two differential diagnoses will have to be kept in mind. Okay. Then progression up to 4 weeks. Then it becomes plateau over next 2 weeks, and then it starts improving. So how long the improvement can happen?
Takes up to 6 months, madam, and only 10%.
6 months to 1 year.
10%
20% maybe.
Residual
20% may be left with a residual weakness. Okay. Okay. It's fine. Can it recur?
Only 2 to 3, less than 5% is recurrence.
Okay. Okay.
This child completely recovered within 1 month, ma'am.
Okay.
After 1 month of follow-up, the child was absolutely normal.
Okay.
In children, it is mostly
There
like
is a
that.
question whether it was answered by Akshaya. Can we again get the explanation regarding the involvement in non-polio enterovirus?
So non-polio enterovirus, actually, it is just like a paralytic polio, it mimics that. Actually, there is a asymmetrical involvement, patchy involvement. Already, Purushothaman sir has mentioned about it. And it is purely motor, and it can produce wasting and weakness asymmetrically also. So that can happen. But this is not a classical presentation. This is all quadriparesis, all four limbs are affected. There is bilateral facial weakness. There is a total areflexia. So all these things are not in favor of a acute flaccid myelitis.
That's a wind up ചെയ്യാൻ തോന്നുന്നില്ലേ?
അതെ, മണി 9:10 ആയി. Thank you, Varghese. Nicely discussed.
Thank you, ma'am.
Thank you, Maxine.
Very good discussion by student also. She answered almost all questions.
Yes, yes.
Srinivasan sir പോയോ? Surma madam, any comments from them? They must have left. That's a pump wind up ചെയ്യാം. Okay.
Okay, sir. Good night.
Thank you.
Manas.